Hello, everyone, and welcome to our little makeup pre-recorded lecture for the end of chapter 11 and the beginning of chapter 12. I appreciate your patience with me needing to reschedule because of my health. Just a few things to keep on your plate as we're looking ahead. The third exam for our course will be 1 week from today when I'm recording this. So it's Thursday, November 13th. If you take your exams in the CAE, make sure you're putting in your reservations to do so now, just to make sure you don't have to deal with any chaos of not getting a room. Also, the information for the second biopsychosocial case conceptualization paper is on Canvas. That document will be due on November 25th, which is the Tuesday right before we go on Thanksgiving break. So just keep that on your radar as well. The plan for our conversation today is to finish up the communication about substance use disorders, and then we'll start talking about personality disorders. A couple of things as well. You will need to do the chapter 11 quiz. It is on Canvas. It's an open book quiz, but you will need to complete it all in one go, and you cannot take it with a friend. You have to take it by yourself. And whatever score you get is whatever is kept. So keep that in mind. It's also timed. You only have 5 minutes to do that quiz. Also, I posted an extra credit opportunity on Canvas for chapter 12 on personality disorders. So if you're interested in that, go to the modules tab and look for the extra credit section and you'll find that opportunity in there. So when we left off in our conversation on Tuesday, we were talking about the different biological treatments for substance-related disorders, but we also have a variety of psychosocial treatments, starting with honestly the sort of dynamic between inpatient and outpatient care. So, inpatient care for substance use treatment means that someone lives in a hospital to receive care. Outpatient then means that they live at home and come in for care, where inpatient is typically much more intensive. The individual is living at the hospital. They are there probably in treatment for 10 to 12 hours a day, and the rest of the time is free time. In outpatient care, you get a much wider variety where it could be you only come in for treatment 1 hour per week, or it could be that you come in for 1 hour of individual and then 3 hours of group per week. It sort of varies all across the board. And what research has found is that there's very little difference in the effectiveness of these treatments as a whole. Like if we just compare inpatient to outpatient, there's very little difference, but rather where we start to see the difference in responses to treatment is whether or not the type of treatment matches what the person is wanting and what the person is needing. This is the key component of substance use treatment because the individual who's receiving the treatment has to be invested in it for it to work. Another option for psychosocial treatment are what we call community support programs. These are the notorious like Alcoholics Anonymous, Narcotics Anonymous, or just general peer-led support programs or peer-led support groups where individuals can hold each other accountable for their work on their own substance use. And these programs can be really helpful for the folks that are interested in them. But when they are mandated, people don't tend to respond quite as well. It's a really important thing as someone working with mental disorders to recognize that you have to balance the treatment goals for each client because complete abstinence is not always the goal for everyone. Some people come in for treatment and they know that they have a disordered pattern with a substance, but they just want to get it to a level that's more manageable. For example, for folks who maybe have a problem misusing alcohol, they might say, I still want to be able to drink. I still want to be able to go to the bar and have one drink with my friends once a month. I don't want to just completely cut this out of my life because that's not feasible when so many things or gathering experiences amongst my friends involve alcohol. So in those cases, we might look into in treatment doing something more like controlled use. How can we get your use to a point where you feel like it is at an acceptable level? And when controlled use is the goal, it changes the type of treatment both in what behaviors are changing, but also the length of treatment. Typically, with controlled use, there are more check ins periodically years down the road to just see how the person is doing. There's also this idea of component treatment, which is the idea of combining traditional psychotherapy with what we call contingency management options. And contingency management in the context of substance use disorders is where you are giving someone a sort of reward for reaching their treatment goals. So, for example, if you have someone who's wanting to cut down on their cannabis use, they might have to do a weekly urine analysis test where they have to collect their urine in a cup and it has to be tested for cannabis. And for every time that they test negative on their urine analysis, they get $5 or they get 5 points that then can be turned in for something. It's contingent. The points or the money or the reward is contingent on the change in behavior. Another option for psychosocial treatments for substance use disorder is what we call comprehensive and prevention programs. Comprehensive treatment programs tend to be the individuals who are going in for both individual and group therapy. So they're seeing an individual therapist to talk about their experience in substance use. And in addition to that, they're doing formalized group therapy. So this is different than what you see in AA, where it is peer led. Group therapy is led by typically one, but most likely two trained and licensed clinicians who are moderating the conversation, and typically everyone in the group is working towards some goal. The combination of individual and group therapy can be really helpful for folks, especially if they're coming out of inpatient. We talk about this comprehensive treatment as like a step down from inpatient, where we're going just a little bit less than 10 hours of treatment a day. Now we're going to step down to you're going to have 8 hours of treatment per week because you're going to have 2 3-hour groups and then you're going to have 2 1-hour individual sessions and then start to step down from there where we cut it back to just one group and one individual and then just individual therapy, and you can sort of back off from there. Another option that comes up for folks is what we call aversion therapy or covert sensitization. Aversion therapy for addiction is usually associating an addictive substance or an addictive behavior with some unpleasant or adverse stimulus. So that can be something like nausea or electric shocks, where the whole idea is that you're trying to pair together the use of that substance with a negative outcome that the person does not like. Because you're really just trying to reduce the individual's desire or their craving for that addictive substance or that addictive behavior. In aversion therapy, you are explicitly tying or pairing the unpleasant stimulus with the behavior or the addictive substance, so the actual use of it. Where covert sensitization is all about making that a mental pairing. So you're going to have it, this is called a verbal aversion technique, where you're going to have the client get deeply relaxed. You might do something like progressive muscle relaxation, where they go through and flex different parts of their body and then release them so that they're in a deeply relaxed state. And then you're going to ask them to imagine scenarios where they are on the verge of engaging in a maladaptive behavior or using a substance. And at the same time that they are thinking about and imagining themselves being on the verge of using, they are going to then start imagining highly aversive consequences to that behavior. So, something that the client has rated as noxious or unpleasant, you're going to ask them to imagine themselves refraining or experiencing that negative outcome when they are on the verge of using. And the whole idea here is that you're trying to help the client reframe their maladaptive behavior around moving away from those consequences that they dislike. Because you want the client to imagine themselves refraining from the maladaptive behavior and feeling better as a result of refraining. So you're really trying to break that association between those maladaptive behaviors or maladaptive use and positive experiences by introducing this adverse consequence. Another option for treatment is what we call contingency management. This is a specific type of behavioral therapy that we just talked about, where an individual is given some sort of reward for moving closer towards their treatment goals of declining their substance use. almost always the reward is some sort of monetary based reinforcer where the individual submits something that shows that they have not used or that their drug use is decreasing. It has to be a concrete thing that they are then rewarded for. We also have what's called community reinforcement. This is a whole approach style community reinforcement where clinicians and patients are working collaboratively to identify individual goals for someone, but then they're applying those goals to the individual's community. So the clinician and the client are going to identify what their substance use goal is, which might be, I want to completely stop drinking. So after they identify that goal, the clinician and the client are going to conduct what's called a functional analysis of substance use, where they take a really close look at what function is served by the use of the substance and try to see what other pro-social behaviors can be introduced besides using that substance. So for example, someone might say if they have a goal of I want to stop drinking, drinking has served as a social outlet for me. It gets me involved with people. There are always people at the bar that I can talk to. My friends are at the bar. So, a pro social behavior that we could introduce instead of drinking might be sober activities. Like, can you go to a pickleball court? Can you go do a picnic in the park? Can you go and um, see a movie with your friends? Other things that are going to be functional in serving the purpose that the substance used, but are moving the person closer to their goals. And we also have relapse prevention, which looks at the learned aspects of dependence and really views relapse as a failure of cognitive and behavioral coping skills. So, looking at and seeing, okay, how do we prevent you from using again? Because you're going to be tempted, you're going to have cravings and a desire to want to use. And what are the coping skills that we can put in place? Things that you can do, people you can talk to, thoughts you can tell yourself that will help you move further away from using. And key with relapse prevention is when someone has a slip, when they start using again, instead of saying, like, this is an inherent problem with you, we talk about this as a failure to use one's coping skills. So making it a little bit more external so that someone's slip doesn't come into a full relapse. A lot of emphasis has been placed on prevention efforts within the substance use community, primarily because historically we have really focused on educating people on substance use. This is really like the DARE programs where you're telling everybody like just say no, and this is what alcohol does to your body, this is how your brain is on drugs. We've sort of shifted away from that mindset and we've gone a lot heavier into the reinforcement of anti-drug laws. So instead of just educating people, how can we reduce access to these harmful drugs that are in our community so that we can reduce the risk for individuals ever attempting or ever engaging in these substances. So that's sort of our treatments for substance use related disorders. There's another category of diagnoses within substance use that's sort of related, and that is gambling disorder. So in the DSM, this is a new diagnosis when the DSM-5 was published, and it is noted by the recurrent gambling that someone engages in that leads to significant distress or impairment. And when we're talking about gambling, we're talking about like sitting at a place where you are spending more money than you have available, and you're doing so repeatedly, like for hours on end in most cases. And there are strong genetic similarities to the biological origins of gambling disorders and substance use disorders, which is why this disorder is categorized with the substance use disorders, because we see folks who have a biological predisposition for developing a substance use disorder have similar predispositions for gambling disorders. So it's almost like thinking about this as like trading one addiction for another in some circumstances. But gambling disorder as a whole is also noted by the required symptoms that are necessary. So, for an individual to have a gambling use disorder, they have to have four or more of the following symptoms in 1 year's time, so in 12 months. They have to have difficulty stopping or reducing their gambling, so an inability to walk away, to stay away for any period of time. Like they might go a couple of months without gambling and then they come back into it. And if they're doing that and they're setting this goal to stop, but they can't convince themselves or they can't convince their behavior to change, that's where we would put this category. We would mark this criterion. There also has to be, as an option, a restlessness or an irritability when someone tries to cut back, like they are on edge in relation to the change in their behavior. Almost always the required symptom is a need to gamble with increasing amounts of money. So the individual is going to start increasing how much they are gambling to the point that they are gambling more money than what they have available. So we're talking about like taking out extra mortgages on their homes, taking out high risk loans, maxing out credit cards, that sort of stuff to gamble because that increasing amount. There's a frequent preoccupation with gambling, so they are thinking about it almost always. They are having a hard time focusing on other things. They are spending a good majority of the time thinking about the next time that they're going to go gambling, what they're going to gamble on, how much they're going to gamble. It is what they think about. They gamble when they are distressed, so they're using gambling as a coping skill. In this regards, it's a maladaptive coping skill, but they're using gambling as a way to treat themselves in some way. Oftentimes with folks, we see them attempting to quote unquote win their money back after a loss. This is a really key component of gambling disorder because in the context of other substance use related disorders, almost always members of the person's family, if they're using alcohol, cannabis, cocaine, LSD, the members of that person's family are going to tell them that the substance is causing them no benefit. The use that they are at, the problematic use that they are engaging in has no benefit. In gambling disorder, though, what we often see is that folks are getting messages from other people in their lives that they just need one more win. They just need to keep going just one more time to win it back. And that's because they're so far in the hole that they have to try to get their way out. But what it ends up doing is creating a cycle of continuing to lose the money in the long run. Oftentimes, these folks also lie about their gambling, so say that they're engaging in other behaviors or that the money is being used somewhere else. This is pretty common. They will at times rely on other people in their life for financial support to support their gambling desires. And they are oftentimes jeopardizing a significant relationship, a job, or an opportunity. So they are not going to work because they're in the casino, or they are lying to their partner in order to continue their gambling behaviors, or they're ignoring obligations in their life. They're not spending time with their significant other, their children, their family members because they want to spend that time gambling. Treatment for gambling disorder is a little bit different than the treatment for substance use disorder because most often we're looking at a psychosocial treatment for substance use disorder that matches what we do for substance use, where we're trying to reduce the symptoms of the gambling disorder by breaking the cycle between the thought and the behavior. So we really want to break up that gambling doesn't make you feel better. In fact, there's a thought that you're telling yourself about engaging in this behavior that is influencing your emotional experience with it. And if we can have a more realistic thought, then we can have a more realistic behavioral expectation. Oftentimes, with treatment for gambling use disorder, dropout is extremely high. People want to get better, but they have to maintain that motivation over time. And once that motivation drops off, we see a lot of folks dropping out of treatment because they're like, this isn't working for me. I'd rather do something else. So, oftentimes, as well, money becomes a huge topic of treatment all of the CBT that you're engaging in is talking about how much money is coming in, where is that money going, what money is being used to pay bills, what money is going to your spouse to pay off debt, like where is the money going? And there are no conversations about someone's gambling use in the past because the research has shown that talking about gambling in treatment is enough of a trigger for people to drop out of treatment and then continue using this behavior. So going out and gambling again. Research on gambling use disorder treatment as a whole is pretty limited, but it's especially limited on more specific types of therapy for gambling use disorders. One of which is what we call multi-part CBT, which is a specific type of intervention that is targeted at gambling behaviors by scheduling alternative activities that someone can engage in, setting financial limits on someone's self, focusing on relapse prevention. It is an emerging technique or modality for gambling use disorders, but the research on its efficacy is pretty limited thus far. So it's something that's in the works, but it's not quite there yet. So that wraps up our conversation on chapter 11. We're going to jump into the conversation on chapter 12, which is all about personality disorders. So before we get too far into personality disorders, I have these icebreaker questions that I want you to pause here and take some time to think through. We're going to talk about these when we come back from the weekend. So we'll talk about these in class on Tuesday, but I want you to take some time to think about what personality is and how we distinguish what's a quote unquote normal or nice personality from a quote unquote weird or disordered personality. So really give yourself a barometer of how you conceptualize personality. So pause this here once you've got a working idea of how you would answer these questions. We'll jump into the next section. So, our overview of personality disorders are that as a whole, personality disorders are an enduring, inflexible predisposition that someone has. So, when I say enduring, what I mean is someone has always been this way. They have since very young, as a toddler, when their personality starts showing through, have had a very inflexible general being about them that is maladaptive in their life. We all hold personalities. We all have parts of our personalities that can be helpful and parts of our personalities that can be maladaptive or harmful. And for folks who have a personality disorder, their personality disposition is almost always, in fact, it is always maladaptive to either them or to the people in their life. And it has to be causing distress or impairment. Interestingly, with personality disorders specifically, the individuals themselves who have been diagnosed with personality disorders often will not report being distressed by their personality. They're going to say that their personality is working for them. It is causing them no harm. They are getting what they need out of the world. So when we talk about the distress or impairment with personality disorders, we are almost always talking about the distress or impairment caused to the individuals around that person. So specifically, is the person who's diagnosed with a personality disorder manipulating their friends and family? Are they causing physical or emotional harm to them? Are they making it so that it is more difficult to have a relationship with this person or to maintain a working environment with them? We really talk about how someone's personality disorder is influencing the people around them because folks who have a personality disorder oftentimes will feel like they are not the problem, that everyone else around them is the problem. We also see a very high comorbidity of all personality disorders across a few different areas, but most often personality disorders are comorbid with one another. So if someone has one personality disorder, they are likely to also be diagnosed with another personality disorder. There are some that are paired together more frequently than others, but just having one puts you at risk for having any more personality disorders. But personality disorders are also comorbid with mood and anxiety disorders, as well as substance use disorders. Prognosis for personality disorders is quite poor. This is because, unlike other disorders, individuals who have a personality disorder oftentimes don't feel like they are the problem. So they don't feel like treatment is necessary. So they don't get the treatment to help their lives be more functional because they don't think that their lives are not functional already. They think everything is fine. And like I said, patients in the context of personality disorders don't feel like they need to go get treatments, which makes it much more difficult for them to live in an environment that is adaptive to both them and the people around them. So, a couple of things on personality disorders. As a prevalence, about 10% of our population is expected to have a personality disorder, at least one. So, this 10% is also going to include the people who have multiple personality disorders. They don't get double counted in this regard. So, about 10% of people in the United States are going to have or meet the threshold for a personality disorder diagnosis. Overall, the cause of or the etiology, like the course of personality disorders, as I've already mentioned, is that they almost always, if not have to start in childhood. We see the beginnings of someone's personality developing very early in their life when they are still an infant and toddler, and those patterns just become more exaggerated as someone gets older, and the patterns themselves become more adaptive or more maladaptive as someone gets older. The course of personality disorders is chronic, especially if left untreated. But even with treatment, personality disorders almost always remain chronic in the sense that when someone is diagnosed with a personality disorder, that diagnosis stays on their medical record forever. There are always circumstances where we put in that we've dropped that diagnosis or that there's not enough evidence to support it anymore. But when that diagnosis is given, it is typically kept as a record to look to see if there is a return of that personality pattern. Sometimes, though, we do see that folks can transition from one personality disorder to another as they go through life. This is because, in general, all humans, not just those with personality disorders, their personalities become a little bit more mellow as we get older. So we will sometimes see folks shift from these more erratic, very dramatic personality disorders to more subdued personality disorders as they go through life. Also, in regards to personality disorders, the gender distribution or bias in diagnosis is present. Specifically, what we see is that those folks who identify as men more often show traits related to things like aggression and detachment, where folks who identify as women are more likely to show submission and insecurity symptoms. And because of that gendered presentation of symptoms, what the DSM has found in their research, or actually the American Psychological Association has found, that there is a distribution of diagnoses. So specifically, antisocial personality disorder is more likely to be assigned to folks who have been assigned male and who identify as men, because that diagnosis is more associated with things like aggression and detachment. Whereas folks who have been assigned female are more likely to be diagnosed with something like histrionic personality disorder, which is more consistent with symptoms of submission and insecurity. So we're seeing that bias in symptoms coming across all the way out to the diagnoses. And as I mentioned before, comorbidity in personality disorders is extremely high, so much so that we talk about comorbidity as the rule and not the exception with personality disorders. Oftentimes, folks will have two or more personality disorders, but they're also at higher risk for experiencing additional mood and anxiety disorders. Substance use disorders are also common depending on the diagnosis. So we talk about personality disorders as being distributed across three clusters in the DSM. So these are clusters that have not changed since the DSM-4 was introduced in the 1990s. We still use these clusters to organize the 10 different personality disorders. So the first cluster is cluster A, which is described as the odd or eccentric cluster of personality disorders. And that is because folks who have one of the diagnoses in this category are exhibiting odd or eccentric behaviors. So the diagnoses in this section include paranoid personality disorder, schizoid or schizoid personality disorder, and schizotypal or oh my goodness, schizotypal personality disorder. You'll hear them pronounced both ways depending on the region where someone's from. So those three diagnoses are considered cluster A, odd, or eccentric. Cluster B is our largest cluster. This is the dramatic, emotional, and erratic cluster. There are 4 diagnoses in this category, and they include antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. And then cluster C, our final cluster, is what we call the anxious and fearful cluster. And the diagnoses included in this cluster are avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So we're going to talk about half of these during this lecture, and then we'll talk about the other half in class on Tuesday. So to sort of jump in, let's go into cluster A and talk about paranoid personality disorders. So remember, this is the odd and eccentric cluster of personality disorders. And the sort of required feature for paranoid personality disorder is a pervasive and unjustified mistrust and suspicion for others in someone's environment. So when we're talking about this paranoia, it's key that the paranoia has to be unjustified. There is no evidence to support why this individual is so mistrustful or suspicious of other people. There may be like one kernel of truth, but for the majority of their paranoia, there isn't enough evidence to back up why that person feels that way. Folks who have paranoid personality disorder tend to have very few meaningful relationships with others. Part of that is because they're extremely sensitive to criticism. They are taking what other people say very literally, and they are also taking more neutral things that people say and putting a negative or a paranoid spin on them. So they're extremely sensitive to the criticism of others, which makes it hard for them to maintain relationships. The causes of paranoid personality disorder are thought to be associated with early learning experiences that people have, that they are told that the people in the world and the world as a whole is dangerous and deceptive, so you have to stay away from it. So it's like these early messages, early childhood messages that people receive that they should never trust others. The world is a dangerous place. People are always going to be out to get you. They're always going to use you. So you need to be on the lookout. There's like an idea or a reference, not a reference, a research support to back up that this is common amongst folks who have been diagnosed with paranoid personality disorder. Treatment for this diagnosis tends to be focused on developing trust. And part of that is because you really want to look at how we can develop trust with other people with evidence. So, in combination with the essential feature of paranoid personality disorder being that the mistrust is unjustified, we're going to look for the evidence of why someone should trust others. And one of the ways that we do that is through cognitive therapy. Really, we're looking at how we can counter someone's negativistic thinking around other people. So, what evidence is there to support that your family, your parents, your siblings are safe for you, are trustworthy people? What have they done that makes you think that they could be trustworthy or that they will continue being trustworthy in the future? Overall, though, we don't have a lot of good outcome studies on treatment for paranoid personality disorder. Part of that is because folks who have paranoid personality disorder are unlikely to come into treatment because they have a mistrust for providers. So when someone does come in for paranoid personality disorders, the therapeutic relationship, the bond between the therapist and the clinician is extremely important in being able for that client to progress through treatment because that mistrust is so high. So it's doing what you can to establish that relationship so that later progress can be made. The second diagnosis in cluster A is schizoid or schizoid personality disorder. And folks who have this diagnosis are sort of essentially featured as having a pervasive pattern of detachment from social relationships. They have no desire to form interpersonal relationships with other people. It is of no interest to them, so they just don't pursue it. And when they are in those relationships with others, they have a very limited range of emotions. So if they are forced into an interpersonal situation, they show very, very minimal reaction to others, emotional expression, because again, they have no desire to engage in those social relationships. The etiology of schizoid personality disorder is unclear, but there is some speculation that it may overlap with autism spectrum disorder as well as childhood shyness. Because a lot of times, what we see is that folks who have both childhood shyness, autism spectrum disorder, or schizoid personality disorder have this unwillingness or lack of desire to engage in social relationships for some folks. A lot of times we also see deviations from this where it's more how people on the outside who are not that person are interpreting their behavior. So where someone might see the individual detaching from social relationships, for folks who maybe have an autism spectrum disorder diagnosis, they might talk about how it's hard to be in relationships because they're extremely uncomfortable because they don't know what to say, they don't know how to interact. Where folks who have schizoid personality disorder might say that they're not engaging in those behaviors because they just don't want to. There's no benefit to them, there is no interest, so they're not going to do it. So when we talk about the connection here, sometimes this is from outsiders looking at the person's behavior and not the person describing their own behavior. Treatments for schizoid personality disorder oftentimes focus on increasing someone's value of interpersonal relationships. So helping them to see that there is a benefit to having those interpersonal relationships. And then once the person is getting that value, a lot of treatment is going to be focused on building empathy for them, how to put themselves in someone else's shoes, how to learn social skills. So how to ask someone for help, how to express when you're having an emotion, how to read someone else's emotions, that sort of stuff. Similar to paranoid personality disorders, very few individuals with schizoid personality disorder will seek professional help on their own. So we don't have a lot of good outcome studies on treatment for this disorder, unfortunately. What you're going to see is a pretty common thing for all personality disorders is we don't have a lot of good solid evidence to support the treatment outcomes, with the exception of borderline personality disorder. So our final disorder in cluster A is schizotypal personality disorder or schizotypal personality disorder, which is characterized by folks who have a behavioral in dress, like style of dress, that is described as being odd or unusual. So specifically for these folks, they tend to be more socially isolated and highly suspicious of other people. So think about these in the context of like combining paranoid personality disorder with the symptoms of schizoid personality disorder, where there's both this paranoia or suspiciousness of others in addition to the social isolation. And in addition to these behaviors, what we also see for folks who have schizotypal personality disorder is that they oftentimes engage in magical thinking. So thoughts that they might have superpowers or that the world is going to solve world hunger like tomorrow, that they are going to be the next billionaire. They also experience what we call ideas of reference, which are the belief that things have special personal significance to that person. So, for example, a person with schizotypal personality disorder might see a certain license plate and think that seeing that license plate is means that they're going to have a good day. or that when they're walking under a street light, if the street light turns off, that means that they are possessed by a demon. It's this idea of reference. So these things in someone's environment have some personal significance to that individual. And they also might experience illusions, which are unusual perceptual experiences that are not as severe as hallucinations. So this can include things like feeling like the presence of another person is with them, even though the person is alone. It's like this feeling for them, but it's not actually seeing or hearing something that's not there. Think of this as like a light hallucination is what an illusion is. Um, Many of the folks who have schizotypal personality disorder also meet the diagnostic threshold for major depressive disorder as well. And some folks conceptualize cluster A schizotypal personality disorder as being a milder form of schizophrenia because of these positive symptoms that are overlapping in both diagnoses. So we're going to talk more about uh, schizophrenia related disorders when we come back after taking chapter or the third exam in this class, because that's chapter 13. But positive symptoms of schizophrenia are symptoms that are added in, like things that are occurring that add to that person's experience. So things like hallucinations, delusions, ideas of reference, they are adding in rather than taking away. So an example of like a negative symptom of schizophrenia might be a flat affect, where we're taking away the emotional range of someone's experience or their expression. And because we see some of that overlap in those positive symptoms of schizotypal personality disorder, that's why some people think that this could be a potential milder form of schizophrenia. With schizotypal personality disorder, the causes of this diagnosis are thought to be partially related to biology, because of that connection to schizophrenia, because people think that schizotypal personality disorder may be a more mild form of schizophrenia, they believe that this diagnosis is an expression of what they call the schizophrenia gene, or this common trait that people have that puts them at risk for schizophrenia. Because if one member of someone's family has schizophrenia, it is more likely to be passed down in that person's family because there is a genetic component to schizophrenia. And people think that if there's a schizophrenia diagnosis, someone could also be at risk for a schizotypal personality disorder, meaning that they are possibly related to that genetic gene. More likely, though, we see that schizotypal personality follows childhood maltreatment and trauma. So children who are exposed to childhood maltreatment, trauma, but especially those who identify as men experiencing those things in their childhood are at greater risk for developing or being diagnosed with schizotypal personality disorder. And overall, the research has sort of pointed in the direction of more generalized brain deficits being present for folks who've been diagnosed with schizotypal personality disorder. So, where there's just like this general idea that their brain is not quite communicating in the way that we would expect it to, but we can't target any specific genes or any specific lobes of the brain that are involved, but rather it's a generalized brain deficit for folks. Treatment options for schizotypal personality disorder are going to address any comorbid depression, oftentimes as a starting point, because that tends to be something that people are interested in and can identify as being problematic for them. So that becomes a little bit of a nice starting point in treatment. The main focus of treatment tends to be on combining medications, typically for the depression, with cognitive behavioral therapy. So we can work on the thoughts that someone is having, in addition to teaching them social skills so that they can develop the skills that are necessary for them to maintain relationships with others. But like all other personality disorders in cluster A, our treatment prognosis is generally pretty poor for this diagnosis. So that wraps up our cluster A diagnoses. We're going to jump in and talk a little bit about our cluster B diagnoses. And we're going to start our discussion with antisocial personality disorder. So to start out, I want to just sort of set the scene that antisocial in the context of personality disorders does not mean the colloquial use of being shy and withdrawn that we hear people say. Rather, antisocial personality disorder in the context of the DSM is more accurate to think of it as meaning anti-society. So, someone who has antisocial personality disorder is ultimately self-interested. They are opposing the basic values that make our civilization functional. They lack trust, cooperation, fairness, morality, nonviolence. Those things are not of interest to them. They do not value them and they do not respect them in others. So, antisocial in the context of this personality disorder is not being withdrawn or shy, it is being counter to our functional society. So, the overall primary feature of APD is a failure to comply with social norms, which makes sense if we think about antisocial and the definition that I've provided. Folks who have antisocial personality disorder are frequently individuals who violate the rights of other people. They are manipulating other people. They may be emotionally or psychologically harming others. It can also be physical manipulation and violence towards others, but just a general disregard for other individuals having rights in favor of the person with the personality disorder getting what they want. These folks tend to be pretty irresponsible, impulsive, and deceitful, partially because they're doing whatever they can in order to get the outcome that they desire. So they don't care if they have to harm someone on the way, even if it's a family member or a friend. They want what they want, and they're going to do whatever it takes to get what they want. Um, Sometimes we talk about antisocial personality disorder as being associated with a general lack of conscious empathy or remorse for others. So these folks have no barometer of right or wrong. They do not care what another person's perspective is. They very rarely feel bad for stepping on people to get what they want or taking advantage of other people because it is all about what they want. Sometimes historically, antisocial personality disorder has been linked to terms of sociopathy and psychopathy. And these are technically separate things. Psychopathy and antisocial personality disorders are typically linked together more often, but the reason why these diagnoses, quote unquote diagnoses, you can't diagnose someone as a sociopath or as a psychopath. Um, but the reason why they're paired together is because they do share some similar traits to one another with this lack of remorse or the violation of the rights of others. But the reason why psychopathy and antisocial personality disorder are linked together more often is because both of those labels are for folks who were born with these symptoms. They're that pervasive maladaptive pattern, whereas sociopathy is something that is developed through someone's environment. Folks who have antisocial personality disorder very often by the individuals in their environment are described as being very charming, but interpersonally manipulative. So these are the folks who the first time they meet someone, they give off a really good impression. Like they're very chatty, they seem to be interested in you, they're asking you questions, they want to get to know you. They're showing you the emotional expressions that they're interested. And then over time, these folks come across as extremely manipulative. Like, oh, they only wanted to know that because they wanted some benefit to them. So they have really good first impressions for folks who have antisocial personality disorder. Very, very nice first impressions, but over time, those impressions wear off and almost sort of like we're seeing the true colors of that person under the surface. With antisocial personality disorder, we see a early history of behavioral problems for these folks. So almost always there is a history of this person being diagnosed with conduct disorder, where the individual is acting in harmful ways to others and to themselves as a child. So these are the kids who are maybe harming animals, like actually physically abusing animals, or are truant from school. They're not going to school. They're skipping class. They don't care if their parents are being charged with truancy. They're breaking the law. They're engaging in substance use very early in life. It's that early pattern of behavioral difficulties that we see being present in early childhood that sometimes evolves into an antisocial personality disorder for folks. Specifically, we see a much higher connection for folks who are diagnosed with the callous, unemotional type of conduct disorder developing into antisocial personality disorder. So, the callous, unemotional type of conduct disorder is those kids that have just a complete lack of regard for other people. They are engaging in the behaviors that they want for themselves. They don't care if it causes them harm. They don't care if it causes other people harm as long as they get what they want out of it. We also see that families that have an inconsistent discipline pattern by the parents and inconsistent support by the parents can sometimes be a risk factor for antisocial personality disorder. So when you combine these things, like the individual already has behavioral problems, and then we couple with that this inconsistent parental discipline, inconsistent parental support, we sometimes see that increasing someone's risk for developing antisocial personality disorder. There does also tend to be a history of criminal and violent behavior amongst that person's family. The closer to the individual who's diagnosed with antisocial personality disorder, the more likely it is to be a risk factor for them. So, for example, if it is an individual who's diagnosed with antisocial personality disorder and their biological father, who they spent time with growing up in their childhood, has a criminal violent history, then that's going to be a much higher risk than if that same individual's uncle that they never see and never spend time with has that history. So the proximity to the person matters in this regard. And as I've sort of alluded to, psychopathy has been linked to antisocial personality disorder in the past, but we are seeing seeing measures of psychopathology as being less reliable as predictors of the criminality associated with antisocial personality disorder. So historically, when folks are engaging in criminal behavior that requires them to be hospitalized, they have to undergo some types of assessments to determine like what their symptom levels are and what they are diagnosed with. And a psychopathy measure is almost always included for folks who are serving a federal prison sentence. And what we found is that how someone scores on those psychopathy measures are not great predictors of later on criminality, but rather there are other indicators specific to antisocial personality disorder that we're investigating as possible predictors. So for antisocial personality disorder, we have a little bit of information around some theories for why someone may develop this. One of those is what we call the under arousal hypothesis, which is this idea that someone is at risk for having an antisocial personality disorder because their cortical arousal level is too low. So, in order for someone who has antisocial personality disorder to feel anything, they need lots of cortical arousal. So cortisol is the stress hormone. So someone needs to experience something that is highly stressful, highly intense in order for them to experience any change. And the underarousal hypothesis would state that people who have antisocial personality disorder, because their arousal level is so high, we have to engage in so much more arousal just to experience any change in arousal. Another theory is what we call the cortical immaturity hypothesis, which is the idea that the cerebral cortex, so that outer layer of our brain, is not fully developed for folks who have antisocial personality disorder, and that then leads to them experiencing or being diagnosed with antisocial personality disorder because the neural connections between the different lobes of the cerebral cortex are not communicating well enough. And the lobes themselves are not fully developed. So if we think about, especially with the frontal lobe, If we're saying that the frontal lobe is underdeveloped, we would be saying that these folks aren't able to plan ahead, they aren't able to think about their consequences before they act, they aren't able to empathize with other, take the position that someone else may have. And because that part of the brain is underdeveloped, they are never going to experience those features or those abilities. There's also what we call the fearlessness hypothesis, which is the theory that individuals with antisocial personality disorder fail to respond to danger cues. So they just have a no response to danger in their world. So they just keep engaging in things that other people would describe as dangerous because to them, it doesn't matter. Like they're not scared. So why should they move away from it? And also, we have what's called the Grays model, which is this theory that folks with antisocial personality disorder have significantly more reward signals than they do inhibition signals. So, in other words, these folks are much more likely to have neural firings that tell them that they are experiencing rewards for something than they are firings for, hey, we should maybe not engage in those behaviors. So inhibition being like, I think I should stop and think about what I'm going to do before I do it. In Gray's model, we say that there are many more reward signals than there are inhibition signals, which is why these folks engage in so many more risky behaviors or behaviors that harm other people to that person's benefit because they don't have enough inhibition signals to outweigh the reward signals. Treatment for antisocial personality disorder is tricky because very few folks with antisocial personality disorder are going to go on to seek treatment. The antisocial personality behavior is predictive of a poor prognosis in treatment, specifically because they're not going to see the benefit in therapy. They're not going to see a need to change their behavior because it is all about what works for me. And if therapy doesn't work for me, but it's for other people in my life, why would I do it? Why would I change myself? Because I'm getting what I want and who cares what other people want? So there's just tends to be a general resistance to engaging in therapy, which means that a lot of times focus is placed on prevention and rehabilitation. So looking at how we can reduce the harm caused to others by working with the other people in that person's environment. So teaching that person how to maintain boundaries with this family member who has antisocial personality disorder, how we can offer them support and rehabilitation but not be involved in it ourselves because that may cause us harm as someone who's not diagnosed. Um, Oftentimes, though, incarceration is viewed as a viable alternative for folks who have antisocial personality disorder. Sometimes their loved ones say, like, there's little that I can do. They're not going to go into treatment. They don't want help. They don't want to make any changes. They're just going to have to get in trouble and just be in a place where I know that they're safe and I know that they're not harming anyone, in theory, that they're not harming anyone. Um, so that tends to be a viable alternative for folks when they're at their wits' end with helping their family member who may have antisocial personality disorder. If you do get someone who's interested in doing treatment for antisocial personality disorder, the goal tends to be to show them that what behaviors they're doing are not working for them. So, for example, you might have someone who decides to rob someone because they want the money. And they're like, yeah, I'm gonna rob them because then I'll get whatever money they've got on them. So I might get like $500. That's amazing. And in treatment, you might focus on saying, like, well, if you rob someone, you'll have to serve time. If you get caught, you're going to have to serve a federal sentence because you already have all of these misdemeanors. So really helping them see that connection between their behavior and a consequence that does not work for them. All right, and then the final diagnosis that we'll talk about in this topic is borderline personality disorder. So again, we're still in that cluster B, so the erratic, dramatic, diagnosed or cluster category. The essential feature of borderline personality disorder is a pervasive and persistent pattern of unstable moods and relationships. So For folks who have borderline personality disorder, they go from very hot to very cold, both in their moods, but in their relationships with others. And when I say very quick, I mean change on a minute. They can go from crying to outright just like rolling on the floor laughing in a matter of seconds. They go from someone being their best friend to someone being their mortal enemy in the matter of an hour. Um, there's just this high volatility between moods and relationships that is characteristic of borderline personality disorder. We oftentimes also see that for these folks who have a BPD diagnosis, it takes more time for them to return to a normal baseline of their emotions. So not only are they experiencing more highs and more lows of their emotions, but they're staying in those high highs and those deep lows much longer. It just takes them harder to get out of it compared to folks who don't have this diagnosis. There does also tend to be a pattern of impulsivity for these folks where they're engaging in behavior without thinking through the consequences, but they also tend to have very poor self-esteem or self-image and a fear of abandonment, which really directly relates into that hot and cold relationship, those unstable relationships, because they are very much so worried about being abandoned. They may at times say, well, if I'm worried that someone's gonna hurt me, then I'm just gonna cut them off so they never have the chance to. It goes from that very hot to very cold very quickly. We do see a pervasive pattern of self-harm and suicidal gestures amongst folks who've been diagnosed with borderline personality disorder. And it's really important to keep in mind that these are suicidal gestures and self-harm and not suicide attempts most often. There are exceptions, but when we talk about suicidal gestures in the context of borderline personality disorder, it tends to be behaviors that are associated with a suicide attempt without ever intending to end someone's life. So engaging in behaviors, I don't love this term, but it's what's used a lot amongst clinicians is that they're doing it for attention. So they're engaging in self-harm in very obvious places that people will see, or they're engaging in very public suicide gestures to try to get people to see, I am hurting, I need someone to talk to me. Borderline personality disorder is highly comorbid with other mental disorders, but particularly comorbid with mood disorders, substance use disorders, and eating disorders. Those are the primary comorbidities for borderline personality disorder. As a cause for personality disorder, we see that there is a strong genetic component. BPD tends to run in families where one family member has it. We're likely to see other members of that family also have it. And we think some of that might be the actual genetic component, but there also might be a heritability of what we call high emotional reactivity, which is this idea that someone is extremely reactive to emotional experiences. So these are the people who have very big emotions, very big high emotions, very big low emotions. And that tendency to have very big emotions can be inherited, can be passed on genetically, which may be putting someone at risk for a borderline personality disorder diagnosis. We do also see and suspect that there may be an impaired function within the limbic system that might put someone at risk. So remember that the limbic system is the border between the midbrain and the cerebral cortex, where we are looking at the connections between our emotion center of our amygdala to the outer portions of the cerebral cortex, like the frontal lobe, where we're able to process emotions. And if we have an impaired bridge between those two, it makes it so that the individual isn't able to cognitively conceptualize their emotions in some cases, making it more difficult for them to act in accordance with their emotions. Almost always, we see early trauma and abuse playing a significant risk for folks who go on to be diagnosed with borderline personality disorder. So, this is not to say that everyone who experiences childhood trauma or abuse is going to develop borderline personality disorder, but rather, what I'm trying to reiterate is that folks who've been diagnosed with BPD are much more likely to identify having experienced those early trauma and abuses. And sometimes we see that as a causal role for that person, where that's when we see the shift occur in their personality is in response to that experience. Some researchers propose that borderline personality disorder is actually a part of the triple vulnerability model, that folks who've been diagnosed have a generalized biological vulnerability within their family. They may have this high emotional reactivity that they've inherited. They may have a family member who has a diagnosis of BPD already, but it's also coupled with a generalized psychological vulnerability of just like having that difficulty with emotion regulation coupled with specific psychological vulnerabilities. So this might be the specific thoughts that someone tells themselves that's maladaptive, like these specific thoughts of, I'm going to cut people out of my life before they ever have the chance to cut me out. So that specific psychological vulnerability and that combination of all three is what pushes someone over the edge for this diagnosis. Treatment for borderline personality disorder is different than any of the other personality disorders that we talk about because it is the only personality disorder that has an empirically supported treatment for this diagnosis. Specifically, borderline personality disorder is treated sometimes by antidepressant medications, and they just provide short-term relief, but psychosocially, dialectical behavioral therapy is the most promising treatment. Again, it is the only empirically supported treatment for any personality disorder, but is specific to borderline personality disorder. Uh, DPD was founded by Marsha Linehan based on her own experience being diagnosed with borderline personality disorder. And she developed DBT on what she thought would be the most helpful for her in living a life that was functional and realistic in her life. And she created DBT to be a very skill heavy modality where it's all about developing the skills that will make someone's life more functional. So there are sort of three pieces to DBT work. And the first of those is helping the person realize the dual reality of both accepting the difficulties that they experience in their life at the same time of recognizing that there's a need for change. So dialectical quite literally means to hold two things at once. And that is exactly what this first piece is addressing is holding that dual reality of I need to accept that my world is going to be imperfect and that things are going to be difficult and that I might not always get things that I think I need. And there are things that I can do to make my life more livable. I can make changes in my environment. So it's being able to hold both of those. Another part of DBT is increasing someone's interpersonal effectiveness. So this is teaching someone social skills, how to identify emotions, how to identify how much our thoughts increase our emotions, how to identify the emotions in others, how to ask someone for help, how to hold a relationship with someone in a way that is functional for everyone in that relationship. And then there's also an incredible focus on what we call distress tolerance. So this is teaching someone coping skills that are helpful to use instead of engaging in reckless or self-harming behaviors. So what are contingencies that we can do? What are other things that might provide us with better relief that is both short-term and long-term efficacious for us? It is good for us in both the short term and the long term. So that's where we're going to end this discussion on chapter 12. I will see you all in class on Thursday for the rest of our discussion of chapter 12, and then we'll talk about the exam. I hope you all have a great weekend, and I will see you later.